Good afternoon, everyone, and welcome to today's Department of Medicine Grand Rounds. I am very excited to introduce our speaker, who I consider both a friend and mentor, as well as someone I admire and look up to a great deal. Dr. Dan Cabrera is a hospitalist at Harborview Medical Center and the University of Washington Medical Center here in Montlake. He's a clinical assistant professor in the Department of Medicine, and he completed his medical school and residency in internal medicine at the other UW, the University of Wisconsin, before joining us in the faculty here. His focus on equity, diversity, and inclusion has led him to serve a number of different roles and different mentorship roles, as well as roles on different committees to help increase the numbers of those historically underrepresented in medicine. He is the Assistant Residency Program Director and the Assistant Student Clerkship Director for Diversity and Inclusion. And last year, he was the inaugural recipient of the Diversity Faculty Mentorship Award from our Residency Program's Diversity Committee. We're thrilled to have him today as our Grand Round speaker to share his experiences and share the efforts that are being done to bolster diversity across the department. As always, feel free to leave questions in the chat, and we will have time at the end for a brief Q&A. Thanks so much, Dan.
All right, thank you so much, Dr. Amalzi. Pleasure to be here. Looking forward to kind of walking you through some of the diversity efforts that have been going on in the Department of Medicine, actually throughout my time here. So let's get started. So I just wanted to start the presentation with making sure that that I did a land acknowledgement, and I'll read it for you, that the UW Medicine acknowledges and honors that the UW School of Medicine stands on the unceded land of the Coast Salish peoples, land which touches the shared waters of all tribes and bands within the Duwamish, Suquamish, Tulalip, and Muckleshoot nations. Without them, we would not have access to this working, teaching, and learning environment, and we humbly take the time to thank the original caretakers of this land who are still here. And for those of you that are curious as to how, why these land acknowledgements sometimes occur or at other times don't occur, I encourage you to kind of look here at this link, nativeland.ca. You can actually plug in anywhere in the world, and it'll tell you what the original indigenous people were to those lands. And it also helps kind of describe, why we do these land acknowledgements. So, disclosures, I don't have any, so that's always an easy one for me. So today, what I'm hoping to do is that we kind of together, right? I'm hoping that even though I'm kind of giving you information, that together we kind of create a shared language around equity, diversity, and inclusion, or otherwise known as EDI. And that we, understand that there was previous and current departmental initiatives around EDI, and that we work together on areas of need in order to advance the EDI goals in our department. So if this wasn't a webinar, I would have done a little poll everywhere or a Zoom poll, but just for the sake of doing the exercise, it'd be curious to know, and just take 5 seconds to yourself to think about what best characterizes your current situation with regard to equity, diversity, inclusion in your work. And so is it something that you use all the time? Is it something that you already have in place to some degree? Is it something that you're interested in doing, but just haven't gotten there yet? Is it something that you're interested in, but not really sure how to start? So I'll let you think about that for a minute. All right, so imagine the poll's up. I would imagine that actually these answers would probably be pretty scattered, that we have a number of people in each of the A, B, C, and D groups. And that's pretty normal from what I've gathered in giving other presentations and talking to people, that I think at this point, people are aware of equity, diversity, inclusion, but there's variability in how it's implemented across the different kinds of roles that we all have. So I wanted to make sure, as I stated in the objectives, that we kind of had a common language around EDI. So first things first, I just wanted to clarify that I personally am going to be using the term EDI when discussing equity, diversity, inclusion. Other spaces, other presentations, you have already heard or may hear things like DEI, which is used for diversity, equity, inclusion, and they are the same thing. And it's just, I think it's kind of user dependent. I prefer the EDI for really the reason that the equity is first, but either one is fine. but just so you're not confused throughout the presentation. So I was inspired last week by Dr. Payne during his talk when he showed some search terms used in literature around hepatorenal syndrome. And while I didn't scour PubMed for search terms of equity, diversity, inclusion, I did go to Google. I'm not saying Google is the be all end all, but I do think it's interesting. And so I put in a number of different search terms. And if you look at the bottom here, the months that are going by actually start when I first came to the University of Washington, which was in August of 2012 to now in April of 2021. And so, I just thought about how I remember kind of coming to learn about these different topics. And I remember people talking a lot about health disparities. And so if you look here, health disparities is this orange line that's kind of jaggedy, but it seems to be rather stable. You can see that per Google, it's been searched and the interest level in it has been pretty steady. There's been some ups and downs and maybe a little uptick recently, but it's kind of been there. And then I remember as I was finishing up my MPH and getting into residency that more and more of the use of the social determinants of health was being used. And you can kind of see that kind of happening here, right? That's this thin green line, and we see it kind of rising. And it actually continues to go up if you were to kind of take the average. Then I just plugged in EDI, so I made that a little more bold here, and it's that blue line. And you can see that really in the past, 2 years, beginning in about 2019, there's been an uptick in just people searching for it, wanting to know more about it. I don't know what correlations or, anything can be drawn, but just interesting to note. I also went ahead and plugged in anti-racism, and that's this thin black line. And you can see that there's really nothing until about April of last year, and then really kicking off in June. And those of you that are probably pretty astute can probably tie that into the murder of George Floyd as probably an impetus for why the search trend for that kind of jumped. It's interesting that unlike the other things, the other terms I've had listed here, that this one tends to be kind of dropping over the past months. I have some ideas about that, but it's hard to say. What you can also do is kind of see where these terms get searched geographically within the United States. And I just thought it was interesting that in that same time period, actually here in the Northwest, the term EDI equity, diversity, inclusion has been searched the most in Portland and Seattle. So maybe that says some positive things about our community. And then to make sure we are all kind of speaking in the same way, I just wanted to make sure we had working definitions that I tend to use around equity, diversity, and inclusion. And I'll let you kind of read through them for a minute. Well, 30 seconds. To summarize how I kind of think about these terms, in an analogy, diversity is being asked to the party. Inclusion is once you're at the party being asked to dance. But really, equity is about being able to come to the party and pick some of the music out, maybe bring some food. So again, there's all sorts of different analogies for this, but that's one I kind of use. So I think it's important to kind of go over, some of the previous, how efforts in, EDI kind of started in our department. And so one of the major kind of milestones is that we had our first African-American female full professor in the Department of Medicine in 2015. And I hope that everyone knows that was Dr. Bessie Young, who is still, part of our department and has recently taken on a big position with the Office of Healthcare Equity to be their medical director arm. In that same year, there was a diversity council that was initiated and led by Dr. Rudy Rodriguez from the VA, also a nephrologist, just like Bessie. And that came from, a call to action, both from Dr. Rodriguez and at the chair at the time, Dr. Bremner. I joined some early meetings and was thinking that maybe we should also try to work on some pipeline programs. So we were able to start our Visiting Scholars program, which is our diversity sub-I. And then around that time as well, Dr. Ken Steiberg of the residency program felt that the issues around EDI could be improved, and asked if there was residents that wanted to gather for a task force at that time. And there was a resident on the task force. And then over the next couple of years, things kind of grew, and Dr. Bremner was able to create funded positions for an associate chair for EDI, that was Bessie Young, and a residency assistant program director for EDI, and that's me. Kind of big news is that was also at the time that once we started, we actually got finally diversity to be front and center on our website, and I think that's important. Then the residency diversity task force actually turned into a residency diversity committee, which I'll talk a little bit more about later. And then in 2019, we also put out our first climate survey, which I'll share some of the results with you in a minute. And then things have continued to progress. We've now implemented a visiting resident scholar program, which Dr. Young mentioned in her State of the Department last month. We had our inaugural diversity retreat last January. We engaged in the BRIM study, which I'll talk about. We now have a staff diversity council. We've got different clinics run by people in our department that are aimed at populations that have been historically marginalized. We have an EDI shared space subcommittee that is meeting and thinking of ways to revamp the physical spaces that we work in at the UW Medical Center to be more inclusive. We now have the Gender Equity Council, which was mentioned at the State of the Department last month. We now have the Diversity Academic Scholars, and we also have forthcoming an LGBTQ+ council. So many things actually have happened in the past 5 years. So kind of moving on to some of the state of things as well. I've got this quote here for those who know him, Dr. Byron Joyner. And this is in reference to comments that he gets around working in EDI, where people will tell him that he seems to be working a lot, and he'll answer with, "Yes, I'm constantly working because there's always work to do." And I feel the same way about issues of equity, diversity, and inclusion. There is no shortage of things to kind of tackle and take on. So I think it's good to kind of see where we are at with who is working as physicians currently in the country. And this is taken from the AAMC, and it just shows you, at least as of 2019, what the kind of breakdown is of physicians in this country. You can see here that the largest part of this pie are people who identify as white, with over half. And then the next largest section is Asian. And I would call out that this is a little, I think, complicated in that, Asian is not a homogeneous group. And this includes Asian and Asian Americans, and also Asians that are actually historically marginalized and not present in good numbers in medicine. And then you can see here that we have unknown, again, people that decline to answer. And then, the numbers start to really kind of dwindle down as far as other groups like those who are Hispanic or Latinx or Black. Again, this is numbers for the entire country. So let's shift a little bit to numbers from our department, which were collected in 2018 by one of our own faculty members and a member of the Office of Healthcare Equity, and that's Dr. Leo Morales. And you can see here, again, I'm gonna go back a little bit, and not the colors don't necessarily align, but I think you'll get a flavor of what's going on here. But again, I don't know that we're as diverse in our department as even the country, right? And it's a little bit of comparing apples to different kinds of apples, in that the other graph was all physicians. But I will tell you that I've looked at the individual numbers from the AAMC for all departments of medicine, and it's pretty similar to the previous graph. So again, I think there's room for work and improvement here. So I'm going to move on to the climate survey that was conducted in 2019. And it was actually 2 years ago. It doesn't seem that long ago, actually, to me, but it was actually modeled after survey work that was done on climate at the University of California, San Diego. And we took their survey, modified it to some degree, made sure that it felt appropriate for faculty and trainees. And so there was 2 different surveys depending on who responded. The faculty response rate was a little under 50%. So you can see the numbers here. But we did have respondents from all divisions at all clinical sites across the department. And there was an even distribution across gender and ranks. In other words, male and female were about the same as far as percentage of respondents. And then the ranks as far as assistant, associate, and full professor were all about 1/3 of those who responded. So I'm going to walk through some of the questions. The first one here is, in the past year, how frequently have you observed or experienced inappropriate behaviors or comments from your patients regarding those domains below? And that includes things like age, gender, race, ethnicity, sexual orientation, sexual identity, disability, religion, and national origin. And, sometimes at first glance, it can kind of be hard to see kind of the trends that you're picking up here. But the way I tend to look at this graph is, if you just look at this first part, which is never, right? People said that this has never happened. And then you can see that some people counted as this happened 1 to 2 times in the past year, some as much as 3 to 6, and some even more than that. But you can see that right off the bat, those that are faculty were experiencing inappropriate behaviors in a disproportionate amount for age, gender, race, ethnicity, right? Those are only at 50% as never, whereas some of these other categories are well above into the 70s and 80s. And then you can see that kind of tracks through. So again, we can kind of see that, based on these things, those people might be experiencing a greater proportion of harm and impact than others. The next question that was asked, one of the questions that was asked was, in the past year, have you experienced or witnessed the following behaviors in your fellow faculty members? And I pulled out some of them, which was, again, blue here is derogatory comments of any kind. Orange is sexual innuendo. This gray here is just outward hostility. And then the yellow is anything that was behavior that seemed like it should be addressed in some way, but just wasn't. And again, I think you can see that even though, there is some things that seem to rarely occur with regards to some of these domains, there were some that actually did occur with some frequency, right? So again, the blue being the derogatory terms, seem to people have experienced that at least one time, if not more. And then I know that we talk about microaggressions a lot, and I think it's important to say what people's experiences. So back in 2019, the question was asked, in the past year, have you known or been exposed to microaggressions in the clinical setting? And again, people were asked to say, how often that occurred. And you can see here that while half of the people have never witnessed or experienced a microaggression, there are some people that are at least, 15% of the people that responded 3 or 6 times in a year, and some even more. And I can make guesses as to who may be experiencing those microaggressions more frequently. And that's something I'll talk about as far as next steps for the climate survey. One of the other questions was, in my opinion, UW provides a supportive environment, and people were asked to talk about who they thought that was receiving a supportive environment. Was it themselves, me? Was it females in the department? Was it males? Was it those who are underrepresented, LGBTQ, transgender, and those with a disability? And I think what's striking about this graph is that the majority of respondents feel that male, faculty members or colleagues are receiving support, but you can kind of see that in some ways they're even thinking that their male counterparts might be receiving more support than them themselves, right? So again, you can kind of see the trends kind of dwindling down. This next one's interesting. It's talking about if people would know where to turn to if they experienced sexual harassment or racial or ethnic harassment or some other form of harassment. I think this one actually, more of almost 80% of those who responded said that they did feel that they knew a way that they could, report or respond or where to turn to if they did experience some harassment. I will say though, on the flip side, it's about 20% total, right, of the respondents that said that they didn't really agree with that statement, that they didn't know who they would turn to. And I think that's an area that we could kind of look into and see what maybe could be improved there. I think it's, sometimes we don't think of burnout as necessarily an EDI issue, but I tend to think it is, because those who experience the most mistreatment in medical institutions tend to be those from groups not historically represented. And so, and we know that those individuals are also more at risk for burnout. So it's just interesting to call this out. So again, people were asked to self-evaluate how much burnout they felt they were experiencing based on their own definition. They were not given a definition of burnout. And, anything that was, in this case, orange, red, or deep red was someone acknowledging that they had burnout or had even worse burnout. And so you can see here that about close to 30% of the respondents were already reporting burnout. And again, even a select few, about 2%, were saying that they were completely burned out. And I think that is important for us to kind of monitor over time. Now, I mentioned again that the trainees, which were residents and fellows, were also surveyed. The response rates were a little lower, but I think that's understandable given how busy residents and fellows can be. Just some things to highlight and how they compared to faculty. There was more female respondents. It was about 60-40 compared to the 48-48 of the faculty. More residents and fellows reported, witnessing inappropriate behaviors compared to their faculty. More of the residents and fellows also felt that they were receiving inappropriate behavior from patients on a number of those domains that I discussed earlier. Interestingly, residents and fellows reported less inappropriate behavior from faculty as compared to their faculty counterparts. But maybe not surprising, residents and fellows also were reporting higher levels of burnout than their faculty counterparts, but had similar levels of morale. So I think some of the next steps for a climate survey is that we just had a meeting this week, and there will be some final data analysis that's going to be forthcoming, hopefully within the next month or two, that we hope to make available to the department to see what's going on. And that's going to really take a look at, across demographic data, who is disproportionately maybe impacted by some of the questions, that were asked of in the survey. We're also in discussions about how and when and with what frequency to kind of repeat a climate survey. We want to make sure that there's enough time between surveys, but also that there's not too much time between surveys. And obviously COVID has really impacted people's perceptions and also real feelings about their value in the workplace. So what are we actually going to do going forward? So some of this work actually started in January of 2020, as I mentioned. We were on a high at that time with EDI work. We actually had our first inaugural retreat. It was on a Saturday afternoon at the Urban Horticulture Center. And we spent the morning doing a SWOT analysis. And I don't expect you to see everything that's on the SWOT analysis. It's just an example of some of the whiteboards that we constructed to kind of think about, again, where we could go moving forward. And then 2 months later, COVID hit, and there was a kind of a lull trying to get back into this work. But luckily, at that same time, later last year, we were able to engage with the Pyramid Consulting, who has been working with department leadership to construct a larger Department of Medicine strategic plan. And so part of that strategic plan includes equity, diversity, inclusion work. And so the key results area was for EDI was group 2. And the overarching statement was to nurture a supportive, collaborative culture where equity, diversity, inclusion are at the center. And the 4 aims were to increase diversity of staff, faculty, and trainees through search, hiring, and retention, utilizing best practices, to have improved climate in the department for all groups historically excluded from medicine. This includes those with identities of BIPOC, female, LGBTQ+, religious minority, and limited ability. Number 3 was to operationalize EDI training, tools, and guidelines for all members of the Department of Medicine to achieve desired outcomes. And number 4 was to create a shared responsibility, collective engagement, and accountability for EDI efforts across the department. I think it looks pretty good. again, some of this work is still to be finalized for posting to the larger department, but it is coming soon. So in thinking about these larger goals, the perspective I have is that, EDI is actually not it should be treated as almost a thread that kind of runs through everything. I think, in my experience, it's been at times kind of siloed. We have this arm and we have this arm, and then we have an arm of EDI. And I think rather than thinking about its own separate arm, I think it's important to think about how it interconnects with all the roles that we have as members of this department, right? Some of us are teachers and mentors, some of us are leaders, some of us engage in a lot of clinical work, some of us in research, some of us in all of these things. I joke that if you're kind of engaged in all those, you're like a unicorn. But again, there's different overlaps around all these roles, and there's some other roles that I'm missing here, so it's not meant to be all encompassing. But the way I think about it is the EDI can actually be at the center of all these roles, right? It can be integrated into your research or clinical work or leadership or teaching and mentoring. And I think if we think about it that way, I think it becomes more sustainable. And I think it also becomes more tangible for people. I also think that, equity, diversity, and inclusion, requires collaboration. So while in the department, we've made great efforts and we've really had a lot of progress, I think it's hard to do it alone. And by alone, I mean alone as one department. And so I think going forward, we're already doing this, but I think it's important for us to kind of leverage connections with the other entities in the institution and actually outside the institution that engage in this work. So luckily, we have an in-house person with the Office of Healthcare Equity, Dr. Young, that can kind of work collaboratively with us. Those of you may or may not know that a bias reporting tool has already been made UW medicine-wide. The Office of Healthcare Equity is also creating an equity framework tool for those who want to take their current work and see and look at that current work with an equity lens. That is something that will be available. Our own faculty member, Dr. Trish Critic, leads faculty affairs, and they are engaging in talks right now to have a faculty development series, which should be rolling out in the next academic year. And again, that faculty development will at times center on issues of equity, diversity, and inclusion. And then there's other departments, right, that we could be collaborating with surgery or pediatrics or urology or what have you. I think there is strength in numbers in this. And I also think that there's a lot of repetitiveness and inefficiency in this work, unfortunately. And I think leveraging the overlap, I think, could be helpful. There are also other departments and institutions outside the UW that are doing great things. We have peer academic institutions that I will occasionally go to their websites and search and seek out what they're doing. And I think they're doing some pretty interesting and innovative stuff. And I think that would be an interesting way to kind of, again, build EDI communities across the country. There's also professional organizations that are really taking this stuff seriously. In the spaces I work in with, the Academy of Academic Internal Medicine or American College of Physicians, they have now working groups and task forces for EDI. And I think there's ways to also, share our knowledge with them and vice versa. And then I think one of the most important things that I don't know that we've done as good a job as we can is to engage communities here in Seattle and King County, right? I think they have a lot to teach us. They have a lot to teach us about the community. They have a lot to teach us about the patients that come from those communities. And I think ultimately that is definitely something we're going to need to do if we're going to provide better care to those patients. So this is all well and good, but I also want to call out that despite, like I showed you, more growing interest in EDI, some things haven't quite changed, right? So this graph that you're looking at here is from the AAMC, and it's just showing matriculants into med school over time. So again, from 1979 all the way to about 2017. Again, we're looking at different demographics, and we see here that we have groups that identify as white and Asian and Black and Hispanic, Latinx, and American Indian, Native Alaska. But we see that the numbers, seem to kind of just slowly increase in the last maybe 10 years for those that are Black and Latinx. but not much, right? So despite the fact that we're calling all this stuff out, you would think that there'd be something that would be a little more appreciable and change. And if you actually look at subsets of some of these things, like for instance, those who identify as Black, we know that Black male students are actually decreasing in numbers coming into med school. So, so something must be going on. I also wanted to bring up this graphic because I think most of us are aware of all the news articles and headlines over the past year about which groups are being disadvantaged most by COVID, right? Those that are unable to seek care for COVID or get vaccinated for COVID. And again, this is a graphic, just, updated by the CDC about, which groups compared to their white counterparts are disproportionately affected by COVID. And you can see here that, for some groups across the board, whether it's the number infected, whether it's the number hospitalized, or the number dying, it's large. And I bring this graphic up not to show you something you already know, but to more think about, if we can think back to a little over a year ago when COVID was starting, this was already being called out as something that could happen. And I think the point I'm trying to make is that even calling out that this could happen, it still happened. So how does that work? How do we still see inequities, even though we're much more focused on equity, diversity, inclusion, and we're making bigger gains? So that's some ideas about that. So one of the things I wanted to call out was that, around that idea of just diversity, but that valuing difference is not an antidote to oppression. And what I mean by that is that, yes, having diversity in your institution is good, but there are still going to be exclusionary barriers that exist, despite the positive intent of trying to bring in more people to increase diversity. And that also inclusion in and of itself is also not a sole antidote to oppression that happens for certain groups. That, trying to work to get, as it's written here, achieving an acceptable, desirable, sufficient number of, fill in the blank persons within an organization does not directly lead to changes in norms and policies, right? There's an expectation sometimes that people from, again, excluded groups, might need to assimilate, and if they don't, they become silenced within institutions. Or if they're not silenced or assimilate, that they are tasked with, engaging in issues around and work around equity, diversity, inclusion at a disproportionate rate than their majority or white counterparts. And I've also seen this idea that we should be talking about equity and inclusion as, a value principle or a business proposition that, this will be good for the business of medicine. This will be good. It brings good value to do these things. And while I'm not saying that isn't true, I think that we should be thinking about it in different ways, because I think if we boil it down to money, I don't know that that's sustainable. Okay. So I'm done talking a little bit at this time about, what maybe could be better about engaging in this type of work. And so I'm purposely shifted this part of the talk to kind of really exemplify some of the things, not all the things, that have been kind of going on in our department, over the past year or so. And on purposely, it was kind of shifted to the back end because I think about it in terms of the 4th of July, which is one of my favorite holidays, and that I always love when there's a fireworks show, when they kind of wait till the end and they let all the fireworks off at once. That's what I'm kind of hoping to do here, is to create some positivity about all these great things that I actually think our department is engaged in. So this is a little screen cap here of our diversity council meeting last August, which grew in numbers following the events of last summer. And I'm happy to see it. And the numbers still kind of continue to be higher than they had been previously. It just makes me happy to kind of see all those people on the call like that. All right. So one of the things that just is wrapping up is BRIM. Almost, it's almost done, but it feels like it's been going on for a while because it has a little bit. And again, it was our bias reduction internal medicine sessions that were split into 2 groups, but the second group's just culminating. And you can see here some of the implementers that were involved in that process. We even had Dr. Roberto Montenegro, who was not an internist, but actually a child and adolescent psychiatrist, join as one of our implementers for group 2. And he's actually taking the BRIM and translating it over into the pediatrics world. And so there will be a BRIM pediatrics rolling out this fall. So it's kind of exciting to see that. As part of the BRIM, those of you who participated in it should have received an email with summarizing statements about your division, at the session you were at. And again, I've pulled the one I'm part of, which is the Division of General Internal Medicine. But they kind of summarized how that group in your session kind of responded to ways that they might work to reduce bias. And you can see here, these were the themes that came out, and each division has a slightly different pie proportion, but the strategies are all the same. So if you haven't seen it, look for it. If you still are missing it, let me know and I will get it to you. But these will be updated onto our website, actually, probably in the next week or two. And then people were also asked to make individual commitments or commitment to action as far as how they might reduce biases in their workspace. And I think, these are some of the examples. Again, these are de-identified, but this one says promotions, review meeting, developing and maintaining consistent, equitable criteria for promotion and speaking up to ensure such criteria are fairly and properly applied. Another one says, my first impulse may be to hang back from building relationships with students from backgrounds different from my own, out of concern that a microaggression that I commit will have significant consequences. Practice an internal motivation message around the benefits of connecting with all students, and a growth mindset message around my ability to apologize sincerely. And then this last one says, a trainee I'm supervising is the victim of a race-based or gender-based microaggression from a patient. And then they say, I will name the aggression, ideally in real time, but at least after the fact with both patient and trainee. And clearly say, not okay, despite presumed non-malicious intentions. Debrief afterwards and be honest about what I did not do well. So I think this shows that there has been an impact from engaging in the BRIM. And I think once the final surveys that are going out in June for group 2 are completed and analyzed, we'll be able to share all that information with you as a department. The next thing I kind of wanted to mention was, who's coming to talk to you like I am. And I think, this is a list that I went back through since 2015 to see who's kind of giving grand rounds and who's engaged, in a grand round that could touch on EDI. And you can see that there is a pattern here, right? That over the past years, there has been an uptick in who's delivering this content. So, and I'm not including here those who may be from, historically excluded groups that we're talking about something not EDI related. So that's something I should probably look into. But, I think we always kind of reference back to, Dr. Kamara Phyllis-Jones, who, again, to this day, I think is still one of the few people to ever have a standing ovation for grand rounds on her talk on, racism and social determinants of inequity. I would be remiss not to mention what the work that the Residency Diversity Committee is doing, or they're commonly referred to the RDC. And some of the highlights is that they continue to just expand and grow with each coming year. It used to be a handful of residents, and now it's at least 14 people in leadership positions, plus other residents that also engage in this work. And they continue out of the goodness of their hearts and souls, and I appreciate it so much. That they, still work to recruit for our residency program in our department, that they, engage in community building activities with each other, and that they really push us to make our curriculum in the residency better. And I give them credit that this year, that our incoming intern class will be the most diverse class that we've had to date. And I think the RDC gets a lot of credit for that in so many ways. They've also started listening sessions in response to real world events. They call it Real Talk. They had their first one last fall in response to the murder of George Floyd and the anti-Black racism that was being called out. and they're actually setting up a second real talk in the next weeks to go over anti-Asian racism and see how people are doing. Some of the members of the RDC were also able to really push through and have a health equity pathway approved by the department and Dr. Young. And there's also been a newly formed LGBTQ alliance with members of the RDC that will continue to work around that. And just to call out here, again, just the amazing work they're doing. I've got a little screen cap here of the 8-page needs assessment that was created in order to propose this health equity pathway. And this is just one little page of it, but it was beautiful and it was well done and it was thorough, and I was pretty jealous of the work they did. And then the second screen cap I have here is of a YouTube clip that the RDC produced as a form of recruitment for those to our program. And you can find it there on the YouTube link, or you could go to the department YouTube page and it's there as well. We still continue to engage in pipeline and recruitment programs. Our diversity sub-I, the visiting scholars program, or as I term it, the VSP, is going to be taking on its sixth cohort this coming summer. And just to call out that since it started in 2015, we've had at least one student that's engaged in this program match successfully into our residency program. And now we've actually started seeing, right, what the intent was is that we have students that engaged in it that became residents and are now joining on as fellows. And in fact, we even have a fellow that's coming into one of our divisions this coming summer that took part in the VSP and chose to go somewhere else for residency, but remembered it so much that they wanted to come back to the UW. And I think that's the kind of stuff that we're aiming for, right? That we're trying to build things that are sustainable. We also have, as was mentioned before, the Visiting Resident Scholars Program, which is modeled at this, where we have residents from other institutions that can come here and rotate with a specific division in the hopes of being able to match into that division. And we did do that with 1-for-1, so we're still 100% on that one. Unfortunately, it's been on hiatus because of COVID, but we are looking forward to having that back starting in winter of 2022. There's lots of ways to engage in EDI. And I think I just wanted to spotlight just two of our faculty members. One is Dr. Rachel Osaka, who is in the Division of Gastroenterology and also Oncology. And if you haven't seen it, I encourage you to kind of read her Peace of Mind for JAMA that she wrote, Good for Us All, where she showed a lot of vulnerability in discussing her experience as a Black woman in medicine. Also here is Dr. Fuki Hisama, who's in the Division of Medical Genetics and was able to write an op-ed about the importance of EDI in medical genetics. And Dr. Hisama has been part of the Diversity Council here since its inception. Other things that happened, I think most of you are aware that, with our chair's leadership, we had the Picture Scientist screenings that took place actually twice, once in October and once in April, and they were followed by discussions. And again, as a way to promote gender equity and also to just highlight the challenges faced by women in STEM. Our staff and our staff leadership have been really engaged in trying to integrate EDI into Core Competency Series. And for those of you that are unfamiliar, the Core Competency Series is a staff development series similar to what might be a faculty development series. And they've already had 2 sessions in the past year. One was responding to microaggressions and one was on inclusive hiring practices. And again, they're looking for more sessions in the future that really touch upon EDI. And unfortunately, I can't go into all of the research that's been done around health disparities, but this is just a sampling of it. And I think this is what we're striving for, right? This is what we're hoping to see in our department going forward, is more people engaging in this, more people receiving funding for this, and making careers, if they want, out of health disparities work. And then finally, on something that's close to home for me is Andrea Campbell, Javelle Cullen, and Whitney Harper from the Internal Medicine Residency Program really took the issues of EDI to heart, and last fall began crafting a newsletter, almost monthly, that really spotlights different groups and cultures, and is trying not to raise competency, but rather raise awareness about that group and culture, and also to help people gain some humility. And I just love the name of the newsletter. Again, maybe why I tend to favor the EDI, but they call it the Editorial. And it's really like a one pager that kind of gives people practical ways to engage, to learn more, right? That could be a podcast, it could be a video, it could be a short reading, ways to support those communities, both locally and nationally, and then also ways to kind of, interact with those communities and cultures, whether it be a local restaurant or a local business. And in the coming weeks, actually, I've already received permission from Andrea, Javel, and Whitney. We're going to put those on our diversity tab for our larger department website so that everybody can have access to this awesome content. So in this last session, I just wanted to talk about kind of where are we going. So my hope is that we become Jedis. And this doesn't come from the idea that I'm the biggest Star Wars fan, although I did really like it as when I was a kid. And there probably is some overlap in what I'm about to talk to you about, but I think more in a term I think that's been growing in the past year or so, Jedi, meaning that it's not just EDI, but it's JEDI or Jedi, and the J standing for justice, right? Justice is defined here as dismantling barriers to resources and opportunities in society so that all individuals and communities can live a full and dignified life. And maybe that's also a reason why I liked EDI, because Jedi sounds better than JDEI. But all kidding aside, I think justice is so important. If any of you have seen me give a talk before, I like this graphic a lot, right? Because I think it kind of, while it's simplistic, I think it really highlights how these things are different. We can see the difference between inequality and equality. We can see the difference between equality and equity. But more importantly, I think it really highlights the difference between equity and justice, right? Justice being that we need to kind of mend those structural things that are creating the inequities in the first place. And I think it's without that justice piece that everything will kind of keep falling back or remaining status quo. I think people who engage in Jedi work or Jedis are those people that you've been exposed to or been around that are using language like racism and anti-racism, oppression and anti-oppression, call in, call out, minoritized individuals, BIPOC individuals. And I bring up this idea of language too, because, EDI is constantly evolving, it's constantly growing, and that there are people engaged in this work that are just, at different stages. Some people are just getting into it. Some people have been doing it their whole lives and are facile with all these words and what they mean and how they actually play out in the work that they do. And so I encourage you all to kind of maybe think about shifting from an EDI mindset to a Jedi mindset, so to speak. And maybe for a more practical approach, sometimes when we talk about work around EDI or Jedi, the phrase of doing the work comes up. And I think sometimes I wonder, what does that mean? Or does everybody know what that means? And I think that can mean it can mean different things for different people. But I think I encourage you, if you go to this link here by Dr. Soto from the University of Indiana, there's very practical things about how to engage in this work and how to show up in your institution with an equity lens. And I don't have time to go through all 42, but I think it's worth taking a look at. So as we're wrapping up here, I just kind of wanted to end with my general philosophy for EDI work. And I think, I think about it in that I hope that in the coming years, our, diversity work will, again, celebrate people in the department who come from groups historically excluded in medicine. I think that we also can find ways to support those same people during times of pain and injustice. that we kind of solidify and confirm the value of EDI work so that it can lead to promotion and advancement for faculty and staff, that we continue to have transparency around our institutional challenges and weaknesses, that EDI is iterative and can be carried out, akin to quality improvement, right? To keep asking the whys of why is it this way, but why can't it be something else? And to circle back, right? Those PDSA cycles. That we create measures of accountability that actually can be sustained, right? I think accountability is a huge piece of this. And that we gain comfort with uncomfortable situations, that's part of this. That's part of the growing and the learning. And that honestly, this last one is the most important, right? That this is all with the understanding that this is going to lead to better patient outcomes and less inequities for our patients. So I always like to leave people with a reflective question. So I'm hoping that, you all, now and over the next year, if someone asked you the following questions, what aspects of your current work have components of EDI, and what are you actively doing to promote and engage in EDI? And are you moving towards becoming a Jedi? And hopefully you clarify that that's not Star Wars, but that's equity work. And I think this again, the work never stops, right? The pain doesn't stop, the injustice doesn't stop. Sometimes I think that there's outcomes that seem positive in some ways, but also seem tragic in other ways as to why that ever had to occur in the first place. And I think something that stuck with me in a presentation I heard around EDI almost 2 years ago was this idea of moral courage. And I put this definition up for you, and I'll read it. And moral courage is the pinnacle of ethical behavior. It requires a steadfast commitment to fundamental ethical principles despite potential risks, such as threats to reputation, shame, emotional anxiety, isolation from colleagues, retaliation, and loss of employment. Morally courageous individuals are prepared to face tough decisions and confront the uncertainty associated with their resolve to do the right thing, despite the consequences they may face. So I hope that you all join me in exhibiting some moral courage as we continue to do this work, because this work is hard. And as someone who is been historically excluded from spaces like this, I need all the help I can get. And I know others probably feel the same. So I thank you for your time. And if there's any comments or questions, I'm happy to answer.
Thanks, Dr. Cabrera. That was a really wonderful and thoughtful discussion. I'll point out, I put a couple links in the chat that you had mentioned just for people to have access to. I may have missed some, so I apologize, but the YouTube video, the department website, and then Dr. Soto's blog. One question that sort of came up as we were going through the slides is, we noticed sort of in the last couple, probably decade, even a little bit less, but that increase in the matriculation of underrepresented minorities into medical schools. Is that reflected in the proportion of students, or is that just a shift that's because the absolute number of medical students matriculating is going up across all races or ethnicities?
Yeah, thank you for that question. Yeah, so the number of students going into medical school is going up every year. So in some ways that makes the numbers look worse, right? So there's actually more spots to fill for seats at a medical school, and the numbers still haven't budged that much. And a point that I forgot to make was this idea of, if we think about it actually as those individuals trying to serve communities that they may be familiar with or similar to or want to go work with, that share a background with them or an identity, let's say Latinx students, right? That graph would not look the same if we were just looking at the population of the United States over the past 20 years, right? Those lines would be much steeper.
Yep.
And so if the numerator is the number of Latinx students and the denominator is the number of Latinx people in this country, we're way behind.
We're actually dropping.
Yes, exactly. Yeah. So
it's a
yeah,
important point. There's a lot of comments just thanking you for this presentation and acknowledging that it's hard over Zoom to hear the audience clap, especially in this panelist mode, and encourage folks to ask questions or comments. I think it's harder to have a conversation in this format, but we're welcome, and we can share things if people want to add their thoughts.
All right.
Seeing a lot of thank yous.
Thank yous are good too. That's,
Yeah. I'll say, yeah, thank you so much for your hard work. And oh, here we go. We've got some questions. A standing applause from a number of folks in the
okay.
audience.
All right.
There's one question came in. Any plan in the works for pipeline programs akin to what others have done, specifically those at Johns Hopkins? So I'm not sure that I'm familiar with the pipeline program at Johns Hopkins, but I'm not sure if you are.
I don't know that I'm from, I don't know which one they're specific. Oh, high school summer scholars.
Okay.
Okay. Yeah. I know that our institution, the University of Washington School of Medicine, does have the SHPEP, SHPEP, that's the Summer Health Professions Experience Program, and that does bring in underrepresented students to get exposed to the health professions in the hopes that they become inspired to continue on, whether it be medicine or nursing or pharmacy. So we do have that here. I know that there's also discussions now more seriously to actually have a post-bac program for students hoping to get medical school admission here. We have not had that. Other schools have and have had a large amount of success, really increasing their diversity with those post-bac programs that often tie right into admission in the same institution.
So not a discrete plan yet, but a lot of interest and a hope that we'll eventually get moving in that direction, it sounds like.
Yes.
Awesome. Thank you for that question. All right. Well, thank you so much, Dr. Cabrera, and thank you everyone for tuning in and continuing to be engaged in these discussions and learn together as we all try to do our part in this work. And enjoy the rest of your Friday afternoon.
Yeah, thank you everybody for your attention. Appreciate you all being here. Thank you.
Appreciate you.